Morning everyone. I hope you all are safe and staying at home. We'll be continuing with our online classes, and today's topic is acute appendicitis and appendicular tumors. We'll be discussing this class under the following learning objectives. Firstly, we'll be reviewing the applied anatomy of the vermiform appendix. After that, we'll be discussing the etiology and the pathophysiology of acute appendicitis. Then we'll come to the symptoms, the classical symptoms, the atypical symptoms, and the signs which help us in making the diagnosis of acute appendicitis. Remember, the diagnosis of appendicitis is mainly clinical, and investigations they just support the diagnosis of appendicitis. Then we'll briefly discuss the hematological and the radiological investigations which are helpful, especially in doubtful cases. And lastly, we'll discuss about the appendicular tumors, the types and the management. So appendicitis is a very common disease and there is lifetime incidence of almost 7%, and majority of these patients they are in young age group, that is 10 to 30 years, almost 70% of the patients. It is the most common surgical emergency which we deal with in emergency and accident department, and the incidence is more in males, especially white population. Almost 16% of the appendicectomies which we do, they turn out to be histopathologically normal. That is why it is called as negative appendectomy. And almost 3/4 of these negative appendectomies they are in the female population. The reason for more incidence of negative appendectomy in the female population is their resemblance with the tubeo-ovarian pathologies of the right side, like right ruptured ectopic pregnancy, ruptured cyst, ovarian cyst, or the hemorrhagic cyst, or twisted ovarian cyst. So all of these conditions on the right side they may make acute appendicitis, and that is the reason of more negative appendectomies in the female population. So acute appendicitis, it can be complicated or it can be uncomplicated. The almost 20 to 30% of acute appendicitis they are found to be ruptured up. That is, the vermiform appendix is found to be ruptured at the time of surgery, and the mortality in complicated cases, that is the ruptured appendicitis, it is almost 3 to 5% as compared to uncomplicated acute appendicitis, that is 0.1 to 0.2%. Now briefly we'll be discussing the applied anatomy of the vermiform appendix. So appendix, that is the vermiform appendix, it is classically defined as blind-ended tubular structure which is connected to the cecum. So you can see that this is the vermiform appendix, this is the ileum, cecum, ileocecal junction. So the characteristic location of the vermiform appendix, it is at the convergence of the three tinea coli. That is, this is the base of the appendix, this is the tip of the appendix, and this base of the appendix is at the level of convergence of three tinea coli. This is the anterior tinea coli. There are two more tinea coli. These three tinea coli converge at the cecum, from where the appendix it arises. It is supplied by the appendicular artery which lies in the mesoappendix. Mesoappendix is the where the appendicular artery lies, and appendicular artery, it is the branch of the ileocolic artery. The average length of the vermiform appendix, it is about 9 cm. Now coming to the positions of the appendix. Appendix positions they vary, and it is not on the basis of the base of the appendix, it is on the basis of the tip of the appendix. So wherever the tip lies, it is known as the position. The base, it is constant, tip, it may vary in position. The most common position, it is the retrocecal, that is behind the cecum. Almost 64% of the patients they have retrocecal appendix. Then pelvic appendix, that is appendix lies in the pelvic cavity, it is seen in 32%, next common. Then there are some rare positions like paracecal, preileal and postileal. So these are again uncommon positions of the vermiform appendix. Now pathophysiology of the development of acute appendicitis. So the most important cause of acute appendicitis, the reason behind the development of acute appendicitis is the obstruction of the lumen of the vermiform appendix, which leads to onset of the bacterial infection, and there is increased intraluminal pressure, which leads to disruption of the lymphatic flow and the development of edema of the vermiform appendix. These are the types of appendicitis. First is the catarrhal appendicitis, in which there is obstruction of the lumen, which leads to distension of the appendix and there is congestion. This is known as catarrhal appendicitis. Then there is appendicular phlegmon or phlegmonous appendicitis, in which there is development of multiple abscess in the wall of the vermiform appendix, and there is collection of purulent fluid inside the lumen. That is known as phlegmonous appendicitis. After that, there is gangrenous appendicitis, in which the appendix it becomes congested and dark red with black necrotic areas. Then there is perforative appendicitis, in which there is necrosis and perforation of the wall of the vermiform appendix, and this may lead to localized or generalized peritonitis. So this is the photograph of catarrhal appendicitis. Here we can see the appendicular phlegmon, in which there is formation of abscess, multiple small abscess with collection of pus inside the lumen. And this is the black necrotic gangrenous appendicitis. Laparoscopic appendectomy is being done in this case. And this is the photograph of a patient with perforative appendicitis. And this is the site of perforation through which a small appendicolith, that is a fecolith, is protruding out. Now the causes of luminal obstruction, which leads to acute appendicitis, which is the main important factor in development of acute appendicitis. It is not fecolith in most of the patients. Fecolith is, or appendicolith, that is the second most important factor. First is the lymphoid hyperplasia, which is seen in 60% of the patients. Is the cause of luminal obstruction. Second is appendicolith or fecolith in 35% of the patients, and there are some rare causes like fruit seeds, worms, and sometimes extraluminal obstruction, example carcinoma of the cecum. It is responsible for development of acute appendicitis. Now the bacteriology. Some aerobic organisms like E. coli, Streptococcus viridans and Pseudomonas aeruginosa, they are found, and anaerobic organisms like Bacteroides fragilis and Peptosporidium. Now let's discuss about the diagnosis of acute appendicitis. The classical symptoms in a patient with acute appendicitis are pain in the abdomen, that is the right lower quadrant. Patient complains of fever, there is nausea and anorexia. These are the classical symptoms in a patient with acute appendicitis. So the pain, it starts around the umbilicus at first, and then there is migration or shifting of pain to the right lower quadrant at the McBurney's point. McBurney's point lies at the junction of the medial 2/3 and the lateral 1/3 of the spino-umbilical line. That is the anterior suprailiac spine and the umbilicus. Medial 2/3 and the lateral 1/3, the junction, it is known as McBurney's point. So why this shifting of pain it occurs in patient with acute appendicitis? The reason is, first of all, there is inflammation of the visceral peritoneum, which is supplied by the autonomic nervous system, and it has got poor pain localization. It has got same innervation as that of the T10 dermatome. So the patient feels pain around the umbilicus. But as the inflammatory process it continues, there is inflammation of the parietal peritoneum, which is supplied by the somatic nervous system, and it has got good pain localization and is supplied richly by the nerve fibers. So the patient feels pain at the McBurney's point. So this is classically known as shifting or migration of pain in patients with acute appendicitis. Some patients, they also complain of fever. So this classical presentation, it is seen in only 60% of the patients. That is the periumbilical pain migrating to the McBurney's point, anorexia, the patient's appetite will be lost, and there is nausea and vomiting. These are the classical symptoms. But in atypical presentation, these symptoms may be, some or all of these symptoms may not be there. Like all the patients may not complain of anorexia. Some patients will complain of urinary symptoms on the right side. It is also one of the differential diagnoses, that is the right ureteric colic is one of the differential diagnoses of acute appendicitis. Some patients may also be having microscopic hematuria. The reason of these symptoms in a patient with acute appendicitis is the position of the appendix. If it is retrocecal, that is seen in majority of the patients. So it will irritate the right ureter, and the patient may be having features of UTI, and on examination of urine there may be microscopic hematuria also. Some patients will be having features of intestinal obstruction, especially who are having a lump or there is localized peritonitis because of perforation. So the patients may develop features of intestinal obstruction. Now, on examination, the patient is typically ill looking and lying still in bed, avoiding any kind of movement, because any kind of movement it will aggravate the pain. So the patient lies still in bed, there is low grade fever and tenderness at the McBurney's point. It is the most important thing. Rebound tenderness in a patient with peritonitis, this sign is known as Plumber's sign. It may be localized or it may be generalized. And cutaneous hyperesthesia in the region of the T10 to T12 dermatomes. Now these are some of the signs which are helpful. The most important sign is the presence of tenderness at the McBurney's point. Now the signs other than the tenderness at the McBurney's point are the Rousing sign. That is when we press the left iliac fossa, the patient will complain of pain at the McBurney's point. This is known as Rousing sign. Then the Dunphy's sign. Any kind of movement including cough will cause pain at the McBurney's point. Then obturator sign, that is pain on internal rotation of hip. And the psoas sign, especially in retrocecal appendix, when the hip joint is extended, the patient will complain of pain. So these are the signs. Now the investigations. First of all, the laboratory investigations. The patient will be having leukocytosis and his counts will be more than 11,000. The polymorphs will be more than 70%. And shift to left, on Arnath count, that is more of immature neutrophils are seen in on Arnath count. And if the counts is very high, that is more than 20,000, it suggests that the patient is having complicated appendicitis in the form of perforation or gangrene. Now coming to the Alvarado scoring. Alvarado scoring is used for making the diagnosis of appendicitis. Remember, there are 8 points in Alvarado scoring. First 3 are the symptoms, next 3 they are the signs, and last 2 are the investigations. Investigations are hematological investigations, not the radiological investigations. That is, the laboratory investigations are there, not the radiological investigations. And the mnemonic for this is Mantrels. Mantrels is not the scoring system. The scoring system is Alvarado scoring, and Mantrels is just the mnemonic. So the first point is migration of pain. Pain starting around the umbilicus, migrating to the McBurney's point. It has been given 1 point. Then anorexia, that is the loss of appetite. It has again been given 1 point. Then nausea and vomiting, 1 point. Focal tenderness at the McBurney's point. Remember, tenderness, not the rebound tenderness. It has been given 2 points. Then a rebound tenderness at the McBurney's point. It has been given again 1 point. Then elevated temperature, that is a fever. It has been given 1 point. So first 3 they are the symptoms. Next 3 they are the signs, and last 2 they are the laboratory investigation, that is leukocytosis. It has been given 2 points, and shift to left, that is more of immature neutrophils on Arnath count, has been given 1 point. Okay, so there are total 8 points: tenderness, and leukocytosis, they have been given 2 points each. The rest all have been given 1 point. So total it is 10. If the score is 7 or more, then we have to proceed with appendicectomy. Now imaging studies, they will just support the diagnosis of appendicitis. In this we can go for plain radiograph of the abdomen, and some patients might show a calcified appendicolate. It is also very helpful in differentiating from other conditions like typhoid ulcer perforation or tubercular perforation or intestinal obstruction, because in this radiograph you will be able to see the air fluid levels or will be able to see the free gas in the abdomen. So it is helpful. The plain radiograph is a very important investigation in the emergency department. There is a plain radiograph of the abdomen. It is also helpful in looking for the ureteric calculi on the right side, which may also have similar presentation. This we have discussed. Now this is a plain radiograph of the abdomen in a patient with acute appendicitis. This is not a very common thing. Almost 10 to 15% of the patients, we have seen very few patients showing this condition, that is calcified appendicolate in the right lower abdomen. So this is again supporting our diagnosis of acute appendicitis. Now the imaging studies, it is the ultrasonography. On ultrasonography, the finding is blind-ended tubular non-compressible aperistaltic structure. The diameter is more than 7 mm in the right iliac fossa. So this is the classical ultrasonographic finding for acute appendicitis. But it is operator dependent and depends upon the presence of bowel gases and the weight of the patient. So this is the ultrasonographic image in a patient with acute appendicitis. Formiform appendix is inflamed, and here again we can see the inflamed appendix. Now the CT scan. The CT scan is helpful in patients who are not having classical symptoms and signs. It is not recommended in all the patient. It has got a sensitivity of more than 95% and specificity was also very high. Use of CT scan for the diagnosis of appendicitis decreases the chances of negative appendectomy from 15 to 20% to only 3%. So these are the CT images in which we can see a calcified appendicolate and the inflamed appendix. So this CT scan, it reduces the incidence of negative appendectomy to almost 3%. Signs of appendicitis on CT scan, it includes the lack of oral contrast. There are two types of contrast which are given. One is the oral contrast and another is the intravenous contrast. So oral contrast will not be present in the lumen of the appendix because of the blockage of the lumen of the appendix and the direct visualization of the inflamed appendix, which is more than 7 mm in cross section, and appendiceal wall enhancement with intravenous contrast. So these are the signs of appendicitis on CT scan. The differential diagnosis of acute appendicitis are, first of all, mesenteric lymphadenitis, ureteric colic on the right side, pelvic inflammatory disease, then Crohn's disease, endometriosis on the right side or right ectopic pregnancy, and typhoid and tubercular perforations. Now the risk factors which are important for development of complicated, that is perforation of acute appendicitis, are extremes of ages. In children less than 10 years and elderly patients. Children less than 10 years, the reason is the omentum, it is not very well developed and which will not properly localize or contain the inflammatory process. You all must be knowing that omentum is the policeman of the abdomen. So it will not be able to localize the appendix because it is not very well developed in children and elderly population because they are immunocompromised. When the patient presents late to the hospital, that is more than 72 hours after the onset of the symptoms, obstructive appendicitis, because it will lead to perforation of the wall of the appendix because of high pressure, and diabetics, steroid dependency, immunocompromised population, and pregnancy. These are again the important risk factors for development of complicated appendicitis. So this is the dictum: no investigation can substitute for the diagnostic accuracy of the experienced hands, which means that the diagnosis of appendicitis is mainly clinical and the investigations, they will only support the diagnosis. Now coming to the management. The management of acute appendicitis is mainly surgical, except in very mild cases. In some recent studies, they suggest that very mild type of appendicitis, if the counts are not so much elevated, if the patient, if the tenderness is not so much, or the pain is not so much, then in that case we can manage the patient conservatively with the help of injectable antibiotics. So, but in most of the patients, surgical intervention is required. So when the patient with acute appendicitis comes to us, we start the management and we start the patient on broad spectrum antibiotics, which will cover the gram-positive, the gram-negative organisms and the anaerobes. Analgesics, they are given once we confirm the diagnosis of acute appendicitis. Otherwise, these analgesics, they will mask the symptoms of acute appendicitis, and then we proceed the patient for laparoscopic or open appendectomy depending upon the available resources. So appendectomy is done, it can be done laparoscopically or it can be done by open technique, and it is usually done as an emergency surgery until unless the patient is having a lump, and we do it as interval procedure after 6 weeks. So the steps of open appendectomy are, first of all, the incisions. The incisions which are used for doing open appendectomy are the gridiron incision, the Rutherford-Morrison incision, Lanz skin crease incision. So all these incisions, they are used for doing appendectomy. They are centered at the McBurney's point. When we split the muscles in the direction of their fibers, that is the external oblique, internal oblique and transversus abdominis, then in that case it is known as gridiron incision. Suppose there are a lot of adhesions and the exposure is not proper on splitting the muscles, then in that case we have to divide the muscles, and that is known as Rutherford-Morrison incision. That is the extension of the gridiron incision. Incision which is more of transverse, centered at the McBurney's point, that is known as Lanz skin crease incision. So all these incisions, they are used, and the muscles, they are divided or splitted. The peritoneum, it is opened, and we will enter into the peritoneal cavity to identify the appendix. So after identifying the appendix, it is delivered outside the wound, and we have to ligate the mesoappendix containing the appendicular artery. After that, we will divide the mesoappendix, and then we will tie the vermiform appendix not more than 3 millimeter from its base. Then we will remove it. So the procedure can be done by open technique, it can be done laparoscopically also. So this is the laparoscopic view of inflamed appendix. This is the vermiform appendix which is inflamed, and the procedure is being done laparoscopically. Now some special types of appendicitis. This is Deger-George hernia photograph, in which the femoral canal, it contains the gangrenous or inflamed appendix. This is the site of femoral hernia which contains this inflamed appendix. This is known as degarangioid hernia. Then Amiens hernia. This is the photograph of one of our patient in which the patient presented with features suggestive of strangulated contents inside the inguinal canal. We opened it and we found that the content was inflamed vermiform appendix, and this is the sac of the hernia. This is known as Amiens hernia. Then Oshner-Sherine regimen. Oshner-Sherine regimen, it is used for the management of appendicular lump. When a patient presents to us, say more than 48 to 72 hours after the onset of the symptoms, then there are a lot of adhesions they form. Omentum, it tries to contain the infection. It forms a lump around the appendix. The bowel, small bowel, also gets adhered to the inflamed appendix to contain the infection. And in that case, the surgery should be postponed for after 6 weeks. That is, if possible. So if a patient comes to us, we keep the patient on Oshner-Sherine regimen and we do careful monitoring of the patient's condition and measure the size of the mass. We have to record the pulse rate, the vitals of the patient, temperature, blood pressure, and we have to keep the patient nil per oral. We start the patient on broad spectrum antibiotics and repeated abdominal examination is done to assess the size of the lump and the general condition of the patient. And if it is successful, then interval appendectomy can be done safely after 6 weeks. If the patient develops a rising pulse rate, or there is increase in the abdominal pain, or increase in the size of the mass, or the patient develops localized or generalized peritonitis, then Oshner-Sherine regimen should be stopped and the patient should be operated. So conservative management, that is the Oshner-Sherine regimen, it is recommended for the management of the patients with abdominal for the management of appendicular lump. But if there is increasing pulse rate or the vitals of the patients they get deranged, in that case we have to proceed for appendicectomy. Now the complications of acute appendicitis, they are wound infection, dehiscence of the wound, intra-abdominal abscess, fecal fistula may be there, intestinal obstruction, there may be formation of bands, and inguinal hernia when there is damage to the ilioinguinal nerve. Now coming to the appendicular tumors, malignancies of the appendix, they are rare, accounting for less than 4% of all the GI tumors, and they are categorized into 3 types. First is the carcinoid tumor, second is the malignant mucocele, and third is the colorectal type of adenocarcinomas. Out of which carcinoids, they are the commonest malignant tumors comprising 55%, then there are mucoceles which are 35%, and rarely 10% of the adenocarcinomas. So carcinoids, they are the most common appendiceal tumors presenting in 4th and 5th decade of life, and in general, if the size of the tumor is more than 2 cm, then there is risk of metastasis. If it is less than 2 cm, then the risk of metastasis is very low. And majority of these tumors, they can be treated with simple appendectomy. At the time of laparotomy, they appear as yellowish nodules near the tip of the appendix, and histopathologically they have small uniform central nucleus with few mitosis. Malignant carcinoid syndrome, which is because of the secretion of the serotonin, is rare with appendiceal carcinoids. It presents with flushing and diarrhea. It is rare in appendiceal carcinoids. And standard recommendation is if the tumor size is less than 2 cm, then simple appendectomy is done. And if it is more than 2 cm, then formal right hemicolectomy is done. Now coming to the mucoceles. Mucoceles, they are the dilated appendix which is filled with mucus, and it represents obstruction of the lumen of the appendix, which may be consequence of cystadenoma or mucinous cystadenocarcinoma of the appendix. If these tumors, they penetrate through the wall of the appendix, then there may be seedling into the peritoneal cavity, and the condition, it is known as pseudomyxoma peritonei. Now coming to the adenocarcinoma, which is very rare tumor of the appendix, and it is of colorectal carcinoma type. Similar to colorectal adenocarcinoma, they also present with adenoma carcinoma sequence. Mean age is around 50 years, and majority of the patients, they are diagnosed intraoperatively. Preoperative diagnosis is difficult to be made because these tumors, they behave like colorectal adenocarcinomas. They should be treated with same aggressive surgical approach, and if there is extension beyond the mucosa, then formal right hemicolectomy along with resection of the mesenteric lymph nodes is